Okay? So what we're looking at is an increased hierarchy in the organization of these cells. So we start out where they're not organized at all. We just have diffuse lymphatic tissue, and we're going to see just scattered lymphocytes, relatively close together, but not in any organized fashion. And these are seen just deep to an epithelium. All right? It could be stratified squamous, as in your mouth or your esophagus. It could be simple columnar in your digestive tract. It could be pseudostratified columnar in your airway, transitional in your urinary tract. All right, but it's a mucous membrane. A mucous membrane is just an epithelium with loose connective tissue. But that epithelium isn't simple squamous. And so that's what's called MALT, or mucosa-associated lymphatic tissue. Okay. So the first classification is this diffuse. So if we happen to break our first line of defense, which is the mechanical barrier of that epithelium, and a pathogen enters into this area, we have, our mast cells, our neutrophils, but we also have lymphocytes that by random chance may happen to have a receptor that matches one of the surface molecules and will mount a defensive component in reaction to that, either the perforin or the antibodies and stuff that we'll talk about next week. But they're not very close together, okay? So the likelihood that they do match is decreased because of the numbers that are decreased. Another mechanism that's not very highly organized but forms a higher concentration involves the use of those reticular fibers. And these are called lymphatic follicles. It actually should have 2 L's, not 1. Most textbooks use the word nodule. I prefer not to because students mix it up with a node. And a lymph node is an entirely different structure that has nodules, okay? But I don't want you to confuse them. So lymphatic follicles is what I prefer to use. And what we have with a lymphatic follicle is a high concentration, and I'm going to use dots so I don't have to do too many. They are held in place by the reticular fibers. They're usually spherical. And so as any particular pathogen moves through that, it has to go, number one, it has to go more slowly. And as it goes more slowly, it has a longer opportunity, plus there's more of the lymphocytes for it to meet up with. There is no capsule around these, all right? So there's no particular organization holding it in place. And so I've likened it, I went inside during the lab tech room during break and cut out a piece of purple. I found a purple one instead of a yellow one for our lymphatic system, sponge. And the sponge is like those reticular fibers, right? So it's going to hold or trap the B cells and the T cells and the macrophages within the spaces in between the fibers and keep them in this higher concentration. But it's still going to be open to any of the tissue fluid diffusing through that area. So here's some histology illustrations. This is showing the small intestine. So these would be the villi of the small intestine, not microvilli, but the villi, finger-like structures that increase surface area. And all these purple dots shown here in higher magnification are B cells and T cells. And we can't tell which, they haven't reacted. And so as any virus, bacteria happen to find its way between the epithelial cells, they're going to find themselves in contact with these scattered lymphocytes. Now they look pretty highly concentrated here, but as you magnify it and you think about how small a bacteria or a virus is, there's still a lot of room around those cells. right? So then we have the follicles. And these are unencapsulated, tighter clusters held in place by the reticular fibers. And sometimes you will see, as you'll see in this next slide where it's the same picture but more higher magnification. So up here is the diffuse, and down here the spherical structures are the follicles. When we find this many follicles in the intestines packed so closely together, we see it in the ileum. The ileum is the last 10 feet or so of the small intestine, and it attaches to the colon, where it's normal to have bacteria living. Bacteria are not normal in the small intestine. Well, there's no gate keeping them away from the small intestine, so they might migrate into the small intestine and get between the cells of the small intestine. And so we have this great population of organized lymphocytes creating this barrier to those bacteria entering into the body tissue itself. Now, we don't have to have follicles, multiple follicles. Here's just a single one, right? So scattered diffuse lymphocytes here. This happens to be in the large intestine. And one single follicle here. So this would be like we see along the skin or the respiratory tract as well. And if you look not too closely, just kind of about the side of the corner of your eye, you can see that the center area here looks different from the periphery. That's because we normally have in our organizational pattern T cells present around the peripheral aspect of the lymph follicle, and in the center, B lymphocytes. And what happens to a B lymphocyte when it starts producing antibodies? It develops more cytoplasm. And that cytoplasm is not going to stain as densely as it did as the nucleus, and so it looks lighter. So when we see a more lighter area within our follicle, that shows that B cells have been activated to plasma cells. So this is known as a germinal center when plasma cells are present. And what it's germinating is antibodies. It's forming antibodies. So it really just shows a reactive follicle.
How come in our picture it shows the whole follicle and it's labeled as the germinal center?
Well, in these other prior ones, the germinal center does take up almost the whole follicle.
Okay.
So here, that's the germinal center. So sometimes they can be as large. All right, so here's where we find the follicles. They can be in the appendix of the large intestine, or just individual follicles in the trachea and the bronchi. Now, I've listed tonsils there because they're part of the malt, but we're going to talk about them separately because they do have part of the structure is surrounded by a capsule. All right, now around this would be lymphatic capillaries. Okay, so as the tissue is percolated through the lymphatic follicle, it will then leave and go into the lymphatic capillaries and then get further exposed to more lymphocytes in the lymph nodes. So we have a model of small intestine, and this is similar to the previous picture. This is kind of representing all of the small intestine, not just the ileum, but here would be the villi, right? Blood capillaries. The gray material is the loose, irregular connective tissue. If you look closely up here, you can see little purple dots. That would be trying to represent the diffuse lymphatic tissue. Down here is a single lymphatic follicle. The green vessels are the lymphatic capillaries. Right. Up in the villus is a single lymphatic capillary known as a lacteal. Remember how they spread apart and allow cells to enter in? The reason we have it here is because when the body absorbs lipids, oil doesn't travel very well in the blood. It can actually cause an embolism because the oil is nonpolar and water is polar. So to help the oil travel better, the lipid, it gets coated with protein before it leaves these cells. LDL, HDL, and now that it's coated with protein, it's too large to get into the capillary. So lipids are actually taken up in the lacteal. So remember I said that our portal vein is high in amino acids and simple sugars? Going to the liver first, for the liver to utilize it for storage or synthesis. Guess how the lipids get to the liver? Hepatic artery. Because the lacteal is going to go up into the subclavian vein to the liver, to the heart, and then back out the aorta. So the hepatic artery is high in lipids, but the portal vein is higher in amino acids and glucose molecules. Okay, and those will eventually get into the arteries too, because all of our organs need them. But the portal vein is higher. So on this model, we'll come back to this with the digestive system in May. But you can see the lymphatic follicle and the lymphatic capillaries, and specifically the lacteal, which is a special lymphatic capillary. All right, so that's a more simple organization in our hierarchy. And now we're going to talk about structures that have capsules. And the lymph node has a capsule around it. All right, so we find this in sequence with our lymphatics. So here's a diagram of where we find lymph nodes. So in your lab list, I don't have you learn lymphatics or trunks, but I do want you to know if I have a whole bunch of lymph nodes along the neck, that cluster of lymph nodes are identified as cervical lymph nodes. And as I indicated earlier, you guys know where axillary region is, and cervical and inguinal and stuff like that. So that's pretty basic. But you can see that the lymphatics are carrying lymphatic fluid towards the heart, and then it will pass through a lymph node, leave a lymph node, and go to another lymph node. Okay? So it does this over and over and has multiple opportunities to become exposed. Breast tissue has this little tail that tapers up towards the axillary area. And so if someone has metastatic breast cancer, one of the first places that it metastasizes to is often at one of the axillary lymph nodes. And that's how they stage breast cancer. So if a woman has a radical mastectomy, they're going to take not only the entire tissue and sometimes the underlying pectoralis muscle, but all the lymph nodes in this region. Okay? And what do you think that does to the loss of fluid, the removal of that excess fluid in the affected limb? It's blocked because it can't go. There's lymph nodes right there. The lymphatics have been removed. And so for quite a few months, the upper extremity on that side is swollen. They often have to sleep with it above their head because as the fluid is not getting back into the capillary system, it's not getting back into the lymphatic system either. All right. Aside from the lymphatics, you can have parasitic infections, elephantiasis, where the parasite lodges in the lymph node and blocks the flow, and they can get huge, elephant size. That's where it gets its name. Lower extremities. If they're a guy, there's images of the scrotal sac going all the way, if they're sitting on a chair, being this big, being all the way down to the ground because of so much excess fluid from blocked lymphatics. All right, so here's the structure of a lymph node, and I'm going to compare it to the histology over on the right, and then I'll diagram it on the board as well. So a lymphatic coming up the leg, if you will, comes to the outer edge. This is like a lymph kidney shaped or bean shaped structure. So if you notice the valve direction, these are all carrying lymphatic fluid into the lymph node for filtration. So the term that we use for going towards is afferent. All right, so these are all afferent lymphatics. After it percolates through the lymph node, it then leaves through the hilum into efferent lymphatics. Well, that's only at the lymph node, because eventually, if we look at this image here, an afferent lymphatic is then going to become, an efferent lymphatic up at here is going to be a afferent lymphatic when it goes into that lymph node, all right? So it doesn't always stay afferent or efferent, it changes location. So we have a dense, irregular connective tissue capsule, and under that capsule is a space crisscrossed by reticular fibers that the lymphatic fluid can flow into, and it can flow down the septi or trabeculae separating the follicles, or it can flow through the follicle itself, right? In a similar fashion to a single isolated follicle under the epithelium, but this has directed lymphatic fluid flowing through it. This whole region here is identified as the cortex. And so the lymphatic fluid either through the follicle or the sinuses flows into the central area, which is the medulla. And so we have medullary sinuses, and then we also have isolated columns or cords of cells. Right? So I made a little model. Now diagram this on the board. But I really was interested in showing you the sponge-like nature of the follicle. So this would be filled with lymphocytes. Now if we take a follicle, and we put it in a capsule. So the baggie would be the capsule, all right? And these little pieces of straw that are falling out of place would be by afferent lymphatics carrying fluid in, and they could flow through the sponge, or they could flow around the sponge, okay? And then they get into the medullary sinus. I was looking for double-sided sticky tape, but they didn't have any. And then it would flow out the efferent lymphatics. It would do that over and over and over on its way back to the heart. So if I diagram that on the board, by the way, as you can see in the next statement, the lymph node is the only one of our organized, or any of our structures, to have afferent lymphatics. All but the thymus will have efferent, maybe in the thymus a little bit, but only the lymph node has the vessels carrying lymphatic fluid to it. So let's draw the capsule, and wait a little second bit before you copy it if you're copying it, because I'm going to have to make openings for my lymphatics. So that would be the trabeculae. Remember how we had the septi dividing the testes into lobules? So we have the connective tissue forming trabeculae. And then I'm just going to draw a circle rather than all the dots for the lymphocytes. There is no membrane around the follicle, so that circle is really just to define the location rather than to indicate any solid structure. So that whole area is considered to be the cortex, all right? Our lymph nodes don't have a dotted line, so this is artificial. But outside that would be the cortex, okay? And then we have 3 different locations of sinuses. Sinuses are where we have those reticular fibers that I showed you earlier, and a lower number of macrophages and lymphocytes. So just under the capsule, lymphatic fluid can flow in here and go either direction. It's going to open up a valve to do so. So this space is known as a subcapsular sinus. Warning, it's not a subscapular. It has nothing to do with your shoulder blade, okay? It means deep to the capsule, but everybody's mouth just wants to say subscapular. But we got used to saying last semester. So subcapsular sinus along just deep to the capsule. Then running down either side of the trabeculae, we have trabecular sinuses. So as the lymphatic fluid flows in, it can slowly percolate through our lymph follicles, or it can flow through the sinuses past the reticular cells and a few lymphocytes and macrophages. All right, I'll go back to the picture in just a moment. Then it enters into the medulla, which is this central area here. And instead of follicles, what we have are cords of primarily T cells. And these are known as medullary cords. So they're formed of concentrations of lymphocytes. T cells. And again, we have our sinuses. And because we're in the medulla, these are known as medullary sinuses. Finally, the fluid leaves the lymph node via several efferent lymphatics, going away from the lymph node, whereas these were afferent or afferent. Lymphatics. Okay. So the lymph node is the only organ that has both afferent and efferent lymphatics. So capsule, subcapsular sinus, trabecular sinus, medullary sinuses. You can see they're not completely empty. They've got those reticular fibers crisscrossing them. Follicle with an outer periphery of T cells and a center of B cells, and medullary cords, primarily T cells. Okay. And next week we'll talk about the difference in each of their functions. So here would be the follicles. Up here would be the subcapsular sinus. Here's the trabecular sinus. Here would be medullary cords, the darker area, and the lighter spaces would be the medullary sinuses. Still with cells and fibers in them, okay, but not as concentrated, so they stay more likely. In fact, this is what a sinus would look like here. That's an artistic rendition. That's not scanning electron microscope. So the next two structures we're going to talk about today, the tonsil has a capsule as well and follicles, but it only has a partial capsule. And then the spleen is a little bit different as well because it's not filtering lymphatic fluid, it's filtering blood. So it has a different role. And the thymus we'll look at on Tuesday next week. So here's the tonsils. Tonsils have a partial capsule because, can I erase this? You guys, you actually have a better diagram. But the tonsils are found in the pharynx. And so their surface covering is going to be the epithelium of their location. One tonsil is found behind the nose, directly behind the nose here, and that's known as the adenoid. On our model, it's colored here in kind of a brownish orange, so straightly back from where air comes into. Okay, so nasopharyngeal tonsil and the nasopharynx. Pharynx is throat, so the nasal part of the pharynx. The other set of tonsils are what you see here. On the side of the back of the mouth, just as you enter into the pharynx. Those are what people most commonly refer to as tonsils. So if you look in your mouth, obviously with your mouth open, here would be tongue. Here would be the soft palate with the uvula hanging down, right? And then there's a couple of arches that come down from that, folds of mucosa. And the palatine tonsils, if you haven't had them taken out, are located right there. So they're also shown in that aspect, same place that you can see up there in that upper diagram. Okay, so this would be the, right here, this would be the tongue. This would be the top of the epiglottis of your larynx, and the soft palate, and there would be the one of the lingual tonsils. These would be the two folds I was talking about. We'll talk about them with the respiratory system. So in this image, here's the uvula. Here are those two tonsils, and here they're very enlarged. All right. So one of our students in the morning class said that she was born with very large tonsils. She still has large tonsils, and she's only had a couple of strep throats, doesn't get a sore throat very often, so they haven't taken them out. Anybody here had their tonsils taken out? Any tonsils besides palatine? And they're the most common. I would get about 10 or 12 sore throats a year. So when I was 5, I had mine taken out. So obviously I'm not going to see anything there when I look in. When we look at the histology of a tonsil, one of the characteristic structures are what we are known as tonsillar crypts, and this is why they're taken out, because they tend to trap. So here would be our regular epithelium, and then in the tonsillar crypts, it goes into deep folds. All right, and we would have our follicles. Well, I can do those in color. We would have our follicles associated. There's no medulla or cortex. We just have the follicles associated deep to the epithelium. And then there is a partial capsule of connective tissue. Just on the deep surface. So one surface is going to have the epithelium, all right? So this would be pseudostratified if it was in the nasal pharynx. And if it's in the mouth, then it is stratified, squamous. So no afferent lymphatics because it's coming from a free surface, but we do have efferent. Okay, sometimes the nasopharyngeal tonsils can be so large that they interfere with breathing. When my nephew was born, 88, he was born a few weeks early. He wasn't tiny, he was 6 pounds, but he was born 3 or 4 weeks early. And he always had trouble breathing, and he would spend all of his energy instead of sleeping when you're supposed to be growing and increasing size and muscle and stuff. He would be struggling to breathe, and he'd have what's called sternal retraction, where they work so hard to create a vacuum that he would have his abdominal wall. You could see his little sternum almost all the way to his backbone. And he wasn't gaining weight because he was using all his energy just to breathe. And so my sister, who worked at Loma Linda as a pediatric heart transplant nurse, took him to pediatrician after pediatrician, and they were just like, well, he'll grow out of it, he'll be okay. And she was a nurse, her husband was in dental school, and they left for 3 weeks on a trip to China to work with dental patients, and her mother-in-law came to take care of her 2 kids. And when she got back, her youngest son was ill, and she spent the entire night after flying 14 hours from China, walking the floor of their home with him. Because every time he fell asleep, he would stop breathing. And she'd wake him up, and make him breathe again. And of course he was exhausted and he'd want to sleep, and she'd wake him up again so that he would keep breathing. And I said, why didn't you take him? I mean, the hospital she worked at was less than 2 miles away. And it's a teaching hospital like UC Davis. And she said, I know the doctors that work there at night, they're not any good. I'm going to wait till the regular staff comes on during the day. So she took him in and they put him in ICU. And then about 3 or 4 days later, they did a surgery and did a tonsillectomy on him. And his pharyngeal tonsils were so large that when he fell asleep, it closed off his airway and he couldn't breathe. When our youngest son, he had enlarged tonsils as well, so he had them taken out, his nasopharyngeal, when he was 14 months. And the doctor said, well, does he, afterwards they asked if he snored or if he breathed through his mouth, and we said no. And they said, well, under anesthesia, when his muscles were relaxed, his nasal airway was completely obliterated because the tonsils were so large, they just filled that airway completely. You also have tonsils at the back of your tongue, all right? So, unfortunately on this model, they're not colored the same brownish orange color as the other tonsils, but here's the tongue, and this tissue right back here at the base of the tongue are lingual tonsils, okay? We have a very large tongue here. It's not human, very thick and fat. So if you like to eat tongue, I suppose that would be delectable, but right here, here's the epiglottis. Right here are the lingual tonsils. Okay. On our small larynx model that has a tongue, included with the model, you can see here's the tongue, here's the circumvallate papillae for bitter taste, and right here at the back. Okay. So when I have my migraine headaches and they make me nauseated, unlike my husband, I prefer to throw up. Sorry for the image. He'll lie perfectly still and do everything he can to not throw up. And I'm like, the sooner you do it, the better you'll feel. So I don't have bulimia, but I do make myself throw up when I have a migraine. So when you put your finger back down there to tickle and activate the glossopharyngeal nerve, that's the lingual tonsil just above the epiglottis that you're feeling. Surface-wise, it's much larger, not right there, but down there. It's much larger than the palatine tonsils or the nasopharyngeal. And I actually had one of my students who told me she'd had her lingual tonsils removed. And I said, I've never heard of that before. And she said, well, she was the first case that her doctor had ever removed. So here would be the circumvallate papillae. Here are the lingual tonsils. And I had a friend of a friend whose young daughter was about 5 or 6, and she would only eat soft food. Soup, applesauce. She wouldn't eat carrots or sandwiches or anything that had to be chewed. And they were on a picnic with a friend of the family who was a rheumatologist, and that's a doctor that works with allergies. And they happened to mention it to him. He noticed that she wasn't eating what everybody else was eating. And he said, well, have you ever had her tonsils checked out? And her lingual tonsils were so large that that was all she could get past them into her esophagus with liquid food. And she wasn't complaining of a sore throat. May have been like the student I had this morning, who was just born with large tonsils. And so they had them taken out, and I'm sure she's enjoying life better. Not having to just drink her way through life, though, I suppose. All right, so those are, again, for histology, I just want you to recognize the histology as a tonsil. So there's really little picture down here. I'll increase it in size. Notice the crypts. So recognizing that as tonsil, where you don't have to identify it, though you could if you could identify the stratified squamous or the pseudostratified columnar, whether it was palatine or nasopharyngeal. But for the histology, just tonsil. Okay? The models, by location, you can identify as nasopharyngeal or lingual or palatine tonsils. Any questions on those? All right, since we have several tonsils, it usually doesn't affect someone's immune system by taking out one of the sets. Okay, so People won't go in there, doctors won't go in there and do it just to do it. But if someone has multiple severe throats where the bacteria is trapped in there and causes them to be enlarged and painful, then it might be suggested. All right, the last organ we're going to do is the spleen. And the spleen is unique in that it has two functions, both having to do with blood. Its lymphatic function is to filter blood, and it also stores red blood cells. So in the fetus, it's a site of development. It has stem cells for blood, all right? But you and I, it's no longer a source for new red blood cells, but it does store them. And if you need additional oxygen carrying capacity, the spleen has smooth muscle in its capsule, and by contracting that smooth muscle increases the internal pressure of the spleen, and the red blood cells are moved back into the cardiovascular system. If those blood cells are old and trying to move in and out of the blood vessels, we have macrophages there that break them down, as well as in the liver. So the spleen is on the left side of the body. It's often a color similar to the red blood to the liver because of the amount of blood in it. So it's over here. Okay, it's much smaller than the liver. It should be anyway. And it's tucked up like the liver under your rib cage. It's not in the thoracic cavity, but your rib cage forms a high dome. And so in accidents in which ribs are broken, if the spleen is severely lacerated, it's often taken out because it's just a bunch of blood cells that are not attached to each other, like epithelial cells are. It's like taking dry clay and trying to hold it together, and it crumbles easily. So once the capsule is torn on the spleen, the rest of it crumbles easily and separates. So if we look at the spleen, it has this capsule, and unlike the other capsules, the spleen and the trabeculae have smooth muscle. So capsule with smooth muscle. Now, again, the spleen filters blood, not lymphatic fluid. So there are no afferent lymphatics coming to the spleen. Again, only the lymph node has afferent lymphatics. So we have the splenic vein we've already talked about, and within the spleen it branches.
Vein or artery?
Pardon?
Vein or artery?
Artery. So if I draw one of those branches separately over here, the lymphocytes are found along the small branches. They're really arterioles, but they're called a central artery. And so they follow that white area that you see in the upper right-hand diagram. They're going to form a sleeve or a sheath. So anything leaving the blood vessel has to pass through these lymphocytes again. And spleen blood vessels are pretty leaky anyway. In cross-section, this looks very similar or identical to the lymphatic follicle. It has the same arrangement of T cells on the outside and B cells on the inside. It will show germinal centers. It has one key difference. Either in the center or offset, it has a blood vessel. All right? That central artery. And these are not present in lymph nodes or any other follicle. So because of its elongated pattern, rather than calling this a follicle, This arrangement is identified as a peri-arteriolar lymphatic sheath. PALS.
Those bundles?
So this right here. I'll show you another diagram. Okay. So here's the peri-arteriolar lymphatic sheath. It's expanded here because there's a germinal center. All right, but it's got this blood vessel running through it. Now that's the lymphatic function of the spleen. And that area, wherever we have the PALS, when we look at spleen tissue, is called the white pulp. All right, so here's a view of the artery and then all the white pulp. And this is what a fresh cut spleen. So let me eliminate that other picture and show you just cut one. So these are the regions where we have the blood vessel and the lymphocytes around them. So that's the white pulp. And the rest of the tissue is where the red blood cells are being stored. And the arrangement of these blood vessels, the capillaries, are the simple squamous epithelial cells, instead of wrapping around them circularly, they run along them the lengthwise, like the wood of an oak barrel. And there's gaps between them, which makes it easy for the red blood cells to move in and out of those vessels for storage or move back in again when the body needs additional red blood cells. So if someone has their spleen removed, right, I have a friend who had some form of liver disease. She has a problem processing copper, and I'm not sure why. But as pressure built up because blood wasn't flowing through her liver easily, her spleen enlarged. And it can get 2 to 10 times its normal size. And it's at risk for rupture, because that puts a lot of tension on the capsule. And a lot of pressure could just cause that to rupture and spill all that blood. And so then you have hemorrhaging within the abdominal cavity. So she had her spleen removed. Someone that's in an auto accident and has a very lacerated spleen may have it removed. So they're going to lose both red blood cell and lymphocyte function. So when they have dental work done, they usually will suggest that they take an antibiotic before that, a series of antibiotics in case bacteria are introduced to their cardiovascular system from the dental work. And they may be more fatigued than someone with a spleen because they don't have those extra red blood cells to add more quickly to the cardiovascular system when they need extra oxygen transport. Alrighty, let's stop there. And let's take your lab quiz at quarter after. Okay? And you can spend the time until then studying for the lab quiz, reviewing. So on your lab quiz, there are 7 questions. 1 question, 4 questions deal with identifying white blood cells or platelets or megakaryocytes. Okay. Actually, I think they're all white blood cells on the quiz, but you do need to know the other ones for the lab exam. 1 question deals with identifying from the equipment what blood test is being, like the centrifuge or the capillary tube for hematocrit and so on, the different blood tests you worked on with your homework. So naming that blood test or value, not the numbers, but the test. And then 2 questions where I show you a tray in which blood testing typing has occurred, and you tell me what the blood type is. So based on the agglutination. All right?